Welcome to the SACNAS Native Initiatives Program webinar series. Today's webinar will feature Dr. Donald Warne, who will be presenting on public health and Indigenous populations. But before we begin, I have a few slides that I'd like to share, information about our organization. I want to welcome our first-time attendees to SACNAS. We are an inclusive organization dedicated to achieving true diversity in STEM, where the field reflects the demographics of our country's population. As the nation's largest multicultural and multidisciplinary STEM diversity organization, SACNAS creates space where all members, partners, and staff feel they belong and can embrace and celebrate their intersectional identities. We invite you to join the SACNAS community at membership.sacnas.org. Now it is my pleasure to introduce our presenter today, Dr. Donald Warne. Dr. Warne is a member of the Oglala Lakota tribe in Pine Ridge, South Dakota, and is the director of the Indians into Medicine. He's also the director of the Master of Public Health Program, Associate Dean of Diversity and Equity and Inclusion, and a professor in the Department of Family and Community Medicine at the University of North Dakota School of Medicine and Health Sciences. He earned his Doctorate of Medicine degree from Stanford University School of Medicine and completed his residency training at the Good Samaritan Regional Medical Center in Phoenix, Arizona, and earned his Master of Public Health degree from Harvard University. Dr. Warne served several years as a primary care and integrative medicine physician with the Gila River Care Corporation in Sacaton, Arizona, and 3 years as staff clinician with the National Institutes of Health in Phoenix. During Dr. Warne's time in Arizona, he conducted diabetes research and developed diabetes education and prevention programs in partnership with tribes. Previously, he served as chair of the Department of Public Health at North Dakota State University. He currently serves as the adjunct professor at the University of Nebraska Medical Center and the Stanford University of South Dakota Medical School, and adjunct clinical professor at the Sandra Day O'Connor College of Law, Indian Legal Program at Arizona State University. Dr. Warne is a member of the National Board of Trustees for the March of Dimes, the Health Disparities Subcommittee for the Centers for Disease Control and Prevention, and the National Advisory Committee for Rural Health and Human Services with the Department of Health and Services. It is our honor and privilege to have with us today Dr. Donald Warne. I'll turn it over to you now.
Well, thank you so much. Very happy to be here with you, Daryl, and I appreciate all of your work through SACNAS. And these Native initiatives and trainings are very important as we look to diversify the STEM workforce, but also recognize that STEM itself has a lot of diversity. And what I'll be talking about today is focused more on public health sciences, but recognizing that we need good public health in Indigenous populations. And I think that's being highlighted right now with the COVID-19 challenge that we're facing. So what I'll talk about today includes issues related to public health in Indigenous populations and some opportunities for training that I'm involved with here at University of North Dakota. So at UND, we have our School of Medicine and Health Sciences, and we have several academic programs within the health sciences, including our MD program, and this is where we house our INMED program, our Indians into Medicine. We also have a physician assistant program. We have a public health program that includes both an MPH or Master of Public Health degree, as well as a PhD program. And we have Indigenous Health Specialization within the MPH and a separate PhD in Indigenous Health, the first of its kind in the world, and I'll talk a little bit more about that later on. And we have several other health sciences and health professions within the school, including occupational therapy, physical therapy, medical laboratory sciences, biomedical sciences, and athletic training. So what is public health? What is it that we're talking about? And again, my training is in both public health and medicine. And I think the easiest way to understand the difference is that in public health, we focus on preventing disease. So public health wants to promote health and prevent disease. And in medicine, we learn how to treat disease. So it really is a continuum of prevention going all the way through treatment and addressing health issues after they occur. So having that combined experience in clinical medicine and in public health, I think is valuable, particularly for Indigenous populations where we have a lot of preventable diseases. This is known as the public health wheel that includes the 10 essential services in public health. And you can see how this is very important right now when we think about COVID-19. So the first essential service is to monitor health. So we need to track diseases in populations, whether it's infectious disease like COVID-19 or chronic disease like diabetes. And if there is an outbreak, we need to diagnose and investigate. And I think we're all getting a lesson in how to do that through contact tracing and investigating outbreaks of COVID-19 as an example. We also have to inform, educate, and empower people. And again, thinking of COVID-19, we could look at informing and educating people regarding the need for physical distancing and wearing a mask and isolation for those who are positive with the disease. We have to mobilize community partnerships. We're seeing a lot of that done in school-based settings right now. Develop policies. Obviously, that has a lot of application right now in terms of policies related to physical distancing and being in public places. And also some of the challenges, if we don't have those policies, we can see super spreader events of something like COVID-19 or influenza or other types of infectious disease when we don't have the policies in place to try to prevent health challenges. We also have to be able to enforce laws. So an example of that, we might have a policy related to secondhand smoke, and we don't want people smoking in public places, but the only way those laws are effective is if they are enforced. We have to link people to services and provide care as needed, assure a competent workforce, and that's a big area of my focus is on helping to develop the next generation of Indigenous health specialists and health scientists. And then we have to evaluate programs and research for new approaches to addressing public health. So those are the 10 essential services in public health. And I love this cartoon. One of the cavemen is talking to the other. He says, something is just not right. Our air is clean, our water is pure, we all get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30. And I think it's important to recognize that even though we have a lot of improvement to make for improving health outcomes in the United States, we've come a long way. And if we think about some of the major achievements in public health, this was developed by the CDC, the Centers for Disease Control and Prevention, and looking at the 20th century accomplishments that includes things like vaccination, so preventing vaccine-controlled infections from occurring by using vaccination, but of course we see challenges there even with pushback against the use of vaccinations, which from a scientific perspective is very unfortunate. Motor vehicle safety is a huge advance. There was a time in history when a seatbelt was an optional item on a car, and it was really the efforts of public health advocates and public health policy that had mandatory seatbelt laws, for example. We have safer workplaces. We used to see many more injuries, disability, and death in the workplace. That's become safer through developing policies and enforcing them through agencies like OSHA, looking at the Occupational Safety and Health Administration. Controlling infectious disease through sanitation as well as vaccination. Decline in deaths from heart disease and stroke. Safer and healthier foods. That's why we have food inspections. Healthier mothers and babies. Our maternal and child health has improved a great deal. Family planning, fluoridation of drinking water, and recognition of tobacco, commercial tobacco, as a health hazard. So we've had a lot of accomplishments in public health over the last century. And if we look at the data, what we find if we look at the year 1900 through 2000, that century, the life expectancy in the United States was 45 years in 1900. So I'm going to be 54 this year. It's hard to believe that I would be nearly 10 years beyond life expectancy in 1900. Fast forward 100 years to the year 2000, life expectancy went up to 75 years. And it's estimated that 25 of the 30 years in increased life expectancy over that century is because of public health, not because of medical care. So preventing disease and promoting health has had a bigger impact on life expectancy than simply treating diseases after they occur. So we know that public health is important, but we also have to recognize that each population is different. So what are the indigenous populations that we refer to? And we use a lot of different terminology when we're talking about our people. So legally, the race, as defined by the federal government, is American Indian and Alaskan Native. So AIAN is the race. And the reason we have American Indian and Alaskan Native is that Indigenous people of Alaska are not all American Indian. There are the Athabascan groups that are American Indian culturally that live in central Alaska, but in northern Alaska, the Inuit populations are actually more of a circumpolar population. So they're around the North Pole in the Arctic region. So you have Inuits in Siberia, Inuits in Alaska, Inuits in northern Canada, and Inuit populations also in Greenland. So they are not American Indian, they're really their own cultural group, but they are Alaska Natives. Also the island chain, the Aleutian Islands that goes into the Pacific Ocean. Culturally, the Aleutian people are much more similar to Pacific Islanders than they are to American Indians from a cultural perspective. So that's why there's overlap. There are some Alaska Natives who are American Indian, but there are other Alaska Natives who are Indigenous but have different cultural groups. So that's why we have American Indian and Alaska Native. We also have a unique consideration among our Indigenous Americans called the enrolled tribal members. So American Indian and Alaska Native is a racial designation, and when we look at science, it's important to understand our data sets. So typically we look at census data for the race, American Indian and Alaska Native, and that's self-reported race or ethnicity. And for enrolled tribal membership, that's different. We have people who self-report as American Indian or Alaska Native on the census, but they may or may not be enrolled in their tribes. So an enrolled tribal member is more of a political designation rather than a racial designation. We also use the term Native American kind of interchangeably with American Indian and Alaska Native. Even SACNAS uses the term Native American. But from a legal perspective, Native American does include American Indians and Alaska Natives, but it also includes Native Hawaiians and Indigenous people of the American Pacific Islands like American Samoa and Guam. So Samoans and Chamorro people in the Pacific Islands are legally and technically Native American. So it's important to really know the meaning of the terminology. So we also use the term Indigenous, and we know that humanity started over 1 million years ago in Central Africa. And over the last 15 to 100,000 years, we've seen huge waves of migration out of Africa all over the globe. And it's those first inhabitants of various parts of the world that are the indigenous peoples. So even though humanity, from a scientific perspective, originated in Africa, the entire planet was populated with people, and it's those first inhabitants of various regions of the earth are the indigenous people. So we have indigenous people all over the world. So we have indigenous people, of course, here in North America and South America, the indigenous peoples of Africa, indigenous people even in Europe, the Sami in Northern Europe, and in Northern Siberia, the Nenets tribes and other groups that are considered indigenous peoples. Also Aboriginal Australians and other Pacific Islander populations that are indigenous people, meaning the first inhabitants of various parts of the world. What's really fascinating when we look at indigenous peoples across the world, there's a lot of similarities that I don't think have been really well described or well understood about those connections. So my people, the Lakota, here in North America, we lived historically in teepees. This picture's over 100 years old. You can see living in communities of teepees. They had domesticated animals, and that was kind of the lifestyle. Around the same time, 100 years ago, the Sami people in Northern Europe, in what is now Norway, lived in teepees and communities with domesticated animals, and actually had very similar clothing and in many ways some similar cultures. So if we look back 100 years, we see a lot of similarities between North America and Northern Europe. What's also fascinating is that in modern times in Siberia, so Northern Asia, people are still living in teepees and have domesticated animals, and the clothing is very similar. So we have some similarities across indigenous populations that I don't think are yet well understood, but that's part of what we are exploring with our Indigenous Health Programming out of UND. So if we look at North America, we know there's a lot of indigenous populations in what is now northern Canada, as well as parts of Alaska. The Athabascan peoples are American Indian, culturally speaking. But then we have, of course, around the North Pole, populations of Inuit people who are not American Indian, but they are indigenous peoples to North America. Then, of course, the plains, the prairies, Great Basin Plateau, Southwest regions, and into Mexico. We have a lot of indigenous cultures in North America. So there's not a single indigenous population, there's hundreds of indigenous cultures. Well, we know a lot changed over the last few hundred years with colonization from Europe. And what we see in the US is similar to patterns of colonization throughout the world, where we had colonization from Europe that then took over lands and marginalized indigenous peoples. And in that process, we see a lot of similarities in terms of poor health outcomes and health disparities. So colonization of populations leads to health disparities. And it's also important to recognize that in the US, colonization started in the East. And that's why we have more people who are indigenous who live in the western half of the United States than the eastern half, because the eastern side of the nation absorbed the brunt of colonization. So where I am from is western South Dakota, and I'm Lakota. So this is the Pine Ridge area, kind of in the central part of the map. And we called ourselves the Oyate, or the Seven Council Fires. Ocheti Shakawi was the Seven Council Fires of Oyate, and that's Lakota, Dakota, and Nakota peoples. Lakota were further west, Dakota further east, and Nakota to the north. So where I work now is in Grand Forks, North Dakota. And the reason it was called the Dakota Territory, and the reason we have North Dakota and South Dakota, is because colonization came from the east. So they encountered the Dakotas first. So it became the Dakota Territory. If colonization had come from the west, it would be the Lakota Territory, and it'd be North Lakota and South Lakota, but that'd be UNL instead of UND, for example. But colonization came from the east, and they encountered the Dakotas first. And the Dakota people occupied what is now the eastern part of North and South Dakota, but also the western part of what is now Minnesota. So this region, Grand Forks, home of University of North Dakota, really is a traditional gathering point for my ancestors, Lakota and Dakota people. And there's actually, the reason it's called Grand Forks is that it's the forks of the Red Lake River heading west and the Red River heading north. And as you go further north into Canada, the Red River then meets the Assiniboine or Nakota River in what is now Minnesota. Comes from two Dakota words that are rising off of the water. So that's a Minnesota. So that area, that region was known as the land of the Minnesota, or now we just call it Minnesota. Well, where I'm from is now called Kyle, South Dakota. The traditional name is Pejutahaka, which means medicine root. And it's the medicine root district of the Pine Ridge Reservation. And we have a lot of challenges with poverty and a lot of social determinants of health. This is a picture of the Little Wound School, named after one of my ancestors, Chief Little Wound. And on the far left is the kindergarten, the far right is the high school. One of the big challenges that we face, that many reservation communities face, is low graduation rates. That for many of our schools, the dropout rate is over 50%. So less than half the kids who start kindergarten actually graduate high school. So it's a big challenge when we ask simple questions like, where is the next generation of doctors going to come from? Where's the next generation of scientists going to come from, or educators or business people? So one of the challenges in public health is that we also have substandard educational outcomes. And we know that poor educational outcomes correlate with poor health status. There's a direct linkage between education and health. Also, the area where I'm from is known as a food desert. Many of our reservations are. This was the cafe there called the Food Stop. It's closed down. The building's still there, but it's not open anymore. But I think what they learned here is that you can bread and deep fry anything and serve it for lunch. So it's not healthy food choices. The types of food that are available are things that could be stored for long periods of time, like food that's frozen, put in a freezer, and then poured into a deep fryer. Is the type of food that's available typically at many of the cafes. Across the street from there is the gas station, and the gas station does double as a grocery store. There's a convenience store here. But as you can imagine, there's not a lot of healthy food options at the convenience store. The closest supermarket from here is in Rapid City, and that's 90 miles away. So just imagine doing a 180-mile round trip to go to the supermarket, and combine that with limited transportation, poverty, and bad weather. It becomes very challenging just to get access to healthy food. One of the outcomes of that is we have terrible disparities in things like diabetes. And this data is actually from North Dakota, but it shows that American Indians in North Dakota have about double the prevalence of diabetes. So about 12.6% of the adult American Indian population has diabetes. 6.5% of the white population among adults has diabetes. The challenge is that there's even a disparity within the disparity. So at any given time, the prevalence is twice as high, but the mortality rate is even worse than that. It's almost 6 times greater. So the mortality rate from diabetes is much worse, meaning people are dying from it at a higher rate. So what this tells us is that if you're an American Indian with diabetes in North Dakota, you have a 6 times greater risk of death from diabetes. So when we think about health sciences, we have a lot of work to do. We need to prevent the disease from occurring in the first place, and we need to do a better job of treatment for the disease. So I know a lot of people who participated in SACNAS have gone into health sciences, whether it's medicine, public health, or research. So in my own family, I come from a family that's closely connected to traditional culture and language and teachings. And historically, we did not have a written language, so we don't have textbooks or history books, but we have an oral history, and we know about our culture and belief systems through stories. And from this region, there's a story of 3 sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister jumps in and says, "This is an emergency, it's a crisis, we need to get the babies out of the water right now." And the second sister thinks about that and says, "No, we need to teach the babies how to swim so they can survive while they're in the water." And the third sister keeps walking upstream, and the other 2 get angry with her and say, "Where are you going? Why aren't you helping us?" And the third sister says, "I'm going to find out who's putting the babies in the water, and I'm going to stop them." And that is literally public health. That is working further upstream. And the downstream needs are tremendous. We need to manage crisis in medical settings. We need to manage chronic disease, like teaching people to swim in the water. Teaching people to manage their blood sugar is kind of the corollary. But we also need public health. We need to prevent the issues from occurring in the first place. And I think that's an area where we have public health science and history and indigenous cultures converging. And we need to work collaboratively to improve health outcomes for our people. I love this old picture. It's one of my ancestors from Pine Ridge. He's a medicine man. And you can see here, it's very different than what we see in the modern clinic. He's touching the patient, praying with the patient, meditating with the patient, and they're with the earth in that process. And I think we have a lot to learn from traditional medicine when we look at our health issues today. And that historically, for those of us who participate in healing ceremonies, the whole community comes together around that ceremony. And the power that you feel when you know that your whole community wants you to be better is indescribable healing power. We do not tap into that very well in modern medicine. So I think in modern medicine, we have a lot to learn from indigenous ways of knowing and indigenous science. And again, bringing those worlds together is the goal for many of our programs. So historically, again, we didn't live as long because we had other issues like injuries and we had infectious disease. But when people were living, they lived in a healthier way. They had healthier food. So of course we had hunters and gatherers, and many of our populations was all free range food, all organic food. Many of our cultures historically were farmers. The picture on the left is from Oklahoma, the one on the right is New Mexico, and tribal people have been farming for millennia. And the food was whole food, right? It was healthy options with whole fruits and vegetables and hunting and gathering of natural occurring food. And if we could combine the best of recapturing traditional food with the best of modern science in preventing and treating disease, I know we can reduce our disparities, but we have to draw from both ways of knowing. One of our big challenges is that we've changed our diet tremendously. And a lot of that is because of commodity food programs. And I'm sure many people are familiar, but the USDA, United States Department of Agriculture, sponsors the Commodity Food Program. And there's a specific FDPIR, Food Distribution Program on Indian Reservations. And some of the foods that were distributed included things like flour and vegetable shortening, used to be lard, salt, sugar, other types of unhealthy food. And what a lot of people don't realize is that the origin of fry bread is not from indigenous people. The origin of fry bread is in the commodity food program. Basically, it's people doing the best they can with their commodities. So you can see on the right, the elder has commodity shortening and commodity flour making fry bread. So it's fascinating how we've adopted that as a culture. I know when I go home for ceremonies or feasts, there's an expectation that there will be fry bread. Well, I always ask why. They say because it's traditional. Well, it's not. It's not our tradition. You know, we never fried dough. So if we want to call it traditional, that's fine, but it's not traditional indigenous food, it's traditional USDA food. And think about all of the science behind nutrition and the science behind the microbiome and even potential epigenetic impact of unhealthy food. No wonder we have terrible disparities. But we can't think of the disparities in the science in a vacuum. It occurs in a cultural context and in a community context. And we have to recognize that the challenges in addressing things like fry bread are multifaceted, and it includes needing to be aware of cultural factors as well. On the left, this is a picture of various commodity foods from many years ago. They had canned beef and canned pork, some almost like a spam-like meat product, very unhealthy. They had egg mix, powdered milk, grapefruit juice, which is basically just sugar water. On the right, this is a bottle of pure corn syrup, which is essentially a poison. And they said, this is USDA, they said, use in your baby formula, use as a syrup for pancakes or French toast. And this is essentially advocating for poison. And the corn syrup is a ultra saturated artificial sweetener that is dangerous. It actually causes diabetes. It causes heart disease. It might be linked to cancer. But this is what food was distributed. So we have to, again, understand history, policy, and science, and traditional culture if we're going to be effective in addressing these disparities. So we have to bring these worlds together. And I think the work being done through SACNAS and the Native programs are really important. I love this image here. It's the difference between equality and equity. And I think in healthcare, we focus on equality. Everyone gets the exact same services, everyone gets the exact same medications, everyone gets to see the same types of doctors, etc., as though one size fits all. But as you can see from this image, if we look at that box that they're standing on is a package of services, package of health services, for example. The guy on the left didn't need it. The one in the middle is being served well, but the guy on the right is still underserved. So in equity, we're not just looking at the package of services, we're looking at the outcomes and how can we raise everyone's health to an equitable level. So it's not just the same services. We have to be intelligent enough to recognize that some people and some populations need unique services. So I've been showing this image for many years, and a couple of years ago, someone sent me a picture that I think is just brilliant. And the question is it about the package of services, or maybe we need to ask, why is that wall there in the first place? So again, we can look at equality with everyone getting the same services, but not good equal outcomes. Then we can look at equity, where we're overcoming the barrier, or we just get rid of the barrier. And from my perspective, one of our biggest systemic barriers in health sciences is that there are not enough Indigenous people in leadership positions and at the front lines of health decision-making. We need more of our own doctors, nurses, public health professionals, researchers. We need more of our own people in those arenas because we have the lived experience that the outside world doesn't. It's amazing how many non-Indigenous people have no idea what the commodity food program is, or even the roots of fry bread, or even history. So we have to have cultural awareness in the sciences. That's vitally important. And I think that one way to break down that systemic barrier of lack of diversity is to build our own training programs. And that's what we're doing at University of North Dakota. So at UND, again, we have the Indians into Medicine program, or INMED program. This program started in 1973. So our second year medical students right now, here in the year 2020, they will be graduating in the year 2023. So the second year medical students at UND are the 50-year anniversary class of INMED. 1973, again, is when it started. And within INMED, we have a lot of programs. We have what's called our Summer Institute, where we do STEM training for middle school and high school students. This year we brought 48 students. We had to do it virtually this year because of the pandemic. Normally we have all the students on campus. We couldn't do that this year because of COVID-19, unfortunately. But we still were able to engage our middle school and high school American Indian students around the nation for training in STEM. And for those who are listening who might either be in middle school or high school or have siblings or nieces or nephews that might be interested in STEM careers or medical careers, we have the Summer Institute. We actually pay the students to come spend 6 weeks with us on campus. And they work in the labs and get good exposure to science. We also have the MCAT prep program, the Medical College Admissions Test. And every one of our students increases their scores in the pre-test to post-test. And it's a 6-week intensive preparation for the Medical College Admissions Test. And that's the admissions test for medical school. This year we had 14 American Indian students participate, which was just wonderful. This year we also have 8 first-year medical students in the INMED cohort. So 8 American Indian medical students as first-year students in the medical program. We have MPH program. We have about 20 students overall in the MPH program, and of that number, I think it's 6 or 7 who are American Indian in the Indigenous Health track. So we have about 1/3 of the MPH students are American Indian. And we just started the brand new Indigenous Health PhD program. And we admitted 19 students into the first cohort. And of the 19, 17 are American Indian or Alaska Native. And one who's Indigenous to Canada as well, so First Nations. So if we look at the 17 first-year PhD students who are American Indian and 8 first-year MD students, in our School of Medicine and Health Sciences, we have 25 first-year doctoral students who are American Indian. And I know it's a record for UND, that's the most we've ever had, but it might be the most of any school to have 25 first-year doctoral students who are American Indian right here at our one school. Within our Master of Public Health, we actually have 3 specializations. In addition to Indigenous Health, we have Health Management and Policy for those who are interested in administration. We have Population Health Research and Analytics for those who are interested in population health research. And everyone in the MPH has the same core curriculum, the basic sciences of public health. And then in the specialization, there's 4 courses within each of those specializations that are unique to that specialization. Then we have what's called an applied practice experience, very similar to like an internship or a practicum. And then we have what's called the integrated learning experience, which is a capstone project. So kind of a final academic product. So 42 credits total, fully accredited MPH opportunity. It's available both online and in person. So for students who are interested in the Master of Public Health, we have a lot of options for students. In terms of the Indigenous Health MPH, I had mentioned there's 4 courses in each of the specializations. The required courses in the Indigenous Health MPH after the core classes of basic public health sciences, we have Principles of Indigenous Health, Social and Ecological Determinants of Indigenous Health, American Indian Health Policy that I teach, and Public Health Programming in Indigenous Populations. So recognizing that those 10 essential services of public health have unique considerations when working with Indigenous peoples. So that's the MPH. In terms of the PhD, and again, it just started this year, it's a 60 credit post-master's doctorate. If a student is full-time, it can be completed in 3 years, but students have up to 7 years to finish it. There's 42 credits in coursework, 6 credits in a seminar series where we have guest lecturers who are Indigenous health scholars from all over the world who talk to our students. And then 12 credits for either the dissertation or portfolio. And for those who are not familiar, a typical PhD includes what's called a dissertation. It's basically your own book on a research topic that you write. So we have that option for academic track, a dissertation for people who want to go into academics and work for a university, but we also have an applied track, which includes a portfolio of 3 products. So rather than one huge volume focused on one area of research, it's got 3 things that can be done, including community health assessments, a grant proposal, published manuscript, policy brief, health strategic plan, etc. So we have options for students who either want to go into academics and work at universities, or more of an applied approach to work perhaps directly within their tribal populations. So just very briefly, the courses include the Principles in Indigenous Health. That's a year-long class. We have applied biostatistics and epidemiology. Then a lot of research methods, including quantitative methods, the numbers, the qualitative methods, which is more answering why something happens, not just what is happening. Then mixed methods, bringing those together. We also have tribally driven research frameworks and Indigenous research methods. As Indigenous people, we've been doing research forever. We just had different terminology for it. Then we also have courses in policy, evaluation, and leadership and ethics. Very proud that our 5 core faculty in the PhD are all Indigenous people. So in addition to me, I'm MD, MPH, and Oglala Lakota. We have Dr. Siobhan Westcott, who has her MD from Harvard, MPH from UCLA. She's at the Baskin from Alaska. Dr. Melanie Nadu, who is Ojibwe from North Dakota. She has her PhD and MPH in epidemiology from the University of Minnesota. Dr. Nicole Redvers, who's from the Dene First Nation in Northern Canada. She's a naturopathic doctor, also has her Master of Public Health from Dartmouth. And Dr. Ursula Running Bear, who is Shichangu Lakota from Rosebud, South Dakota. And she has a PhD in clinical sciences and a master's degree in sociology. And combined, our faculty has about 100 years experience in Indigenous health. So for those who might be interested in this degree program, you'll learn from people who actually worked in the field for many, many years. And if you have any questions about it, you can always reach out to me. My email address is right here, donald.warne@und.edu. All right, I'll go ahead and end it there and hand it back over to Daryl.
All right. Well, thank you, Dr. Warne. While we still have you here, just a little time, I did have a follow-up question for you. And thank you again for sharing all of that information. And I know that I've been sharing information about the UND programs with my network. And so it's really great to hear and see those numbers. So the question that I have for you is pertaining to COVID-19. And I know that you've been providing information and giving talks and writing articles. And I'm curious to kind of learn more, and I would like to enlighten our SACNAS community about the impacts that it's currently having on our American Indian and Alaska Native people in our communities. And what can you share with us are those current challenges that we're facing, and what can we do as STEM educators to help, and even just being Native people. What more can we do?
Yeah, and unfortunately, COVID-19 has hit many of our tribal populations quite severely, and the CDC just put out a report last week, so mid-August of 2020, that showed about our rate of COVID-19 is about 3.5 times greater than the white population. So unfortunately, we are overrepresented among the COVID-19 infected people. And there are reasons for that. So when we're addressing something like an epidemic or a pandemic from a public health and medical perspective, we have what's called the 3 T's. First is testing, and the second is contact tracing. And those are just bread and butter public health services. That really is public health. And I think one of the challenges is that we have not had adequate investment in public health infrastructure in tribal populations. So we don't have the same types of capacity to respond to a pandemic that we see in a larger city or a suburb where there's more resources. The third T is treatment. So that's where you get into the medical side when someone is diagnosed. Again, testing, tracing, and treatment. And again, with underfunded health systems, we don't typically have intensive care units or ventilators in reservation communities. So they have to be sent off reservation, in some cases hundreds of miles away to receive treatment for something like COVID-19. So just having a lack of adequate infrastructure puts our people at risk, but also not just risk for the disease, but risk for death. So we have higher death rate as well. So in addition, when we have underfunded public health programs and lack of public health infrastructure, we also see higher rates of risk factors for bad outcomes. So we have higher rates of heart disease, lung disease, and diabetes. And if you have any of those conditions, you're at a 6 times greater risk for hospitalization and death from COVID-19. Throw on top of that, poverty and overcrowded housing. How do you do quarantine or isolation when you have overcrowded housing? So not surprisingly, some of our tribal communities have just been devastated by COVID-19. And you can see the importance of public health, the importance of prevention in the first place, as well as the importance of treatment. And that's why we need to bring these worlds together of public health, medicine, policy, research, and traditional culture. That's the only way we'll be successful. It's a multifaceted problem, so we need a multidisciplinary approach.
Great, thank you for sharing those words and that information. I know that will be very helpful for our young and upcoming STEM researchers to hear. So with that, I'm going to share my screen. We want to invite each of you to join us for our 2020 SACNAS, the National Diversity in STEM Conference, which will be fully virtual this year and include online keynote speakers, mentoring and networking opportunities, a graduate school and expo hall, and beautiful cultural celebrations. To learn more, visit 2020sacnas.org and register. Again, thank you for joining us for this webinar, and we hope that you all stay safe, and we will see you next time.